Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graben.
Hi, this is Mark Graben. Welcome to episode 354 of the podcast. It is January 8th, 2020. And joining us today is Kim Hollon. He is the CEO and president of Signature Healthcare, which is based in Brockton, Massachusetts. I first met Kim about a decade ago, and as we discovered during the podcast discussion, one of my favorite lean healthcare clients from Dallas was later an important influence in Kim's own discovery and embrace of lean. But what specifically prompted the podcast interview here was Kim's recent article, an outstanding article titled "The Healthcare Leader's Role in Safety." I blogged about it not long ago. So in the episode, we will talk about the article, his personal history with lean, and much, much more. So if you want to find a link to that article, the 1999 report to Err is Human, and other things that we talk about here, you can find all of that, including a video of Kim, a separate discussion where he talks about a culture of safety. You can find all of that by going to leanblog.org/354. If you don't already do so, I would invite you to subscribe to the podcast wherever you found or normally find or subscribe to podcasts. If you like the podcast, this episode and beyond, please do consider rating and reviewing the podcast. And for the general podcast feed and more information about where to subscribe, you can go to leancast.org. So again, our guest today is Kim Hollon. Kim, thanks for being a guest today. How are you?
I'm great, Mark, and thanks for having me on. I've followed your work for years. Tremendously impressed in what you've been able to help healthcare accomplish, and excited to be on with you today.
Oh, well, thank you. I appreciate that. And, we're going to talk about the important work that you've been doing at Signature Healthcare and your article. But before we get into that, I always like to let people tell their own story a little bit, if you don't mind, introducing yourself. And I'm curious, in particular, if you can talk about, how you got to, what your interests were, how you got into senior leadership roles in different health systems.
Well, I was fortunate, Mark, to get into senior leadership roles early in my career, but I got interested in healthcare when I was a sophomore in college and went to work as an orderly in a small community hospital in Alabama. And after finishing undergraduate school at Montevallo, went to University of Alabama, Birmingham, and received my graduate degree in hospital administration from them. That took me to Dallas, Texas, where I completed my administrative residency at Baylor University Medical Center during the early years of Baylor's expansion, both into non-healthcare business, sort of vertical integration, horizontal integration, as well as the establishment of their multi-hospital system in those early years. So I was promoted quickly, rose on the staff at Baylor, and then went to Methodist Hospitals of Dallas as a president of one of their hospitals when I was only 29. During the years I was at Baylor, I got really interested in quality improvement. I was actually doing some quality circles back in the early 80s, then learned about value stream management and TQM when I was at Methodist and taught some of the courses there. I now understand what I was doing was touching part of Toyota production system, but never really realized I was touching a system. I just saw it as what I was hearing and trying to implement, but never realized there was a management system underlying it.
Yeah. Well,
anyway, I was so fortunate to come up in healthcare at a time that some of us were promoted probably before we should have been or were ready to, but I broke into senior leadership really early in my life.
Yeah. Well, I'd like to hear a little bit more about how you got exposed to TQM, but I just wanted to comment first that I just got back from Japan again, and when I've been there, it's been a little surprising that I've met somebody who is now retired from Toyota, and he was responsible for Toyota's total quality management, or TQM, initiatives, even in recent years. And I think a lot of people view TQM as being something maybe from the past, but I've seen within Toyota and other organizations there that quality circles and practices like that are still very much active today. But I'm curious your thoughts on how you got introduced to that originally. Was that part of was there a bit of a trend there in the 80s, or what was your personal experience?
I've always been a really curious person and really curious about how industries outside of healthcare work, because I've always thought leaders in healthcare often came from healthcare and we were too inbred. And I remember a program on television that was like an hour long or something about the automobile industry and about Ford and quality being one, talking about the rehabilitation of the American auto industry. And I think that was the first introduction I had to quality circles and total quality management. And I was a young vice president at Baylor looking for tools and ways to help the people that reported to me. So I began looking and studying about what that was, really saw it as tools in process at the time. But I think got interested through the story about the American automotive industries. And I didn't see much adoption at all in healthcare at the time.
Okay.
And then got interested, I think probably deeper, at some point ran across Deming's material and Duran's material. I don't know what had me do that, like 7 or 8 years later, but I know I was struggling to get alignment at the hospital I was the president of, struggling to find a way to get sustained quality improvement over time. Started reading the materials, and I went to my boss, the president of the multi-hospital system, David Hitt at the time, and said, "Hey, Dave, you might be really getting into what's going on with Duran and Deming and doing some self-study and implementing what I can at my own hospital." And he always let me run as far as I could. He got interested in it and started reading the books, and then for like 2 years probably, we did these Friday group studies of Deming, Duran, and watched videos as a senior team of a 3-hospital system, really trying to self-educate ourselves. And that was before you saw much adoption at all in hospitals. And we wound up hiring a lady from the New York phone company, 9X, to come down and teach value stream mapping and team-based quality improvement in our organization, and set up a department to do that. And I would say that's still late 80s, early 90s.
Well, and you mentioned, and you touched on this in the article as well, that back then you were viewing, paraphrasing what I heard you say about TQM in the 80s, that it was about tools and process, but you came around to see all of this, and maybe including lean, as being, as you describe in your article, more of a not just a philosophy, but also as a management system. What do you think led to that kind of evolution in your view of all this?
Well, I had the privilege of having a wife who was also a manager in healthcare systems. She was a director over at Children's Hospitals of Dallas, and I would frequently download with Ellen my frustration with conducting town hall meetings at Methodist round the clock, about 24 one-hour meetings in a stretch of a month and a half, trying to assess our organization's alignment and how people understood what we were trying to accomplish as an organization. I was always frustrated that even in some departments where they were doing great work, the people on off shifts and evening shifts had no idea what they were working on. They even had no idea that they had done a great job. And I found that frustrating. I was downloading to her one day, and she said, "Kim, I don't know what this guy's done, but we have a lab director over at Children's. He keeps talking about alignment and the improvements he has in his department, and I've never seen anybody this excited about leadership before. If you want me to make an introduction, I will." And so I went over to see the lab director at the time, and I think you may have used them as an example before, but they had Johnson & Johnson in.
That was
and had
I was
implemented.
I was the person from Johnson and Johnson. This was
Oh,
probably
were you?
this was Jim
So
Adams. Jim Adams is the
yeah,
lab
so
director. Yeah.
so you'll appreciate this. I went over to Jim Adams for an early morning meeting, like 8 o'clock in the morning, and I left Jim Adams' office for what was supposed to be a 1 hour meeting, something like 3 to 4 hours later. He gave
Yeah.
me 4 or 5 books to read and a message. Kim, what we've done is incredible, but this is a leadership system, and
Yeah.
senior leadership has to understand it and buy into it. And here's some books. He gave me Toyota Way, Toyota Field Book. He gave me
Mm-hmm.
Man's book on culture
Mm-hmm.
and supervision.
Mm-hmm.
And he said, you need to go read these. And before you think about implementing anything you've done, you need to see this as a management system. So I started reading, and it began to lay out to me the Toyota production system. And it was a crescendo to me of 20 years worth of administrative work, taking parts of a system, well-meaning, trying to make change, and then suddenly seeing the system provided to me. It's like, oh, I never realized that the frustrations I was having was because this was a management system and I was implementing the pieces separate from each other.
Mm-hmm.
But they worked as a system, and if I'd implemented it as a system, I'd get more traction. That was a dramatic event for me. And Jim was so passionate, and I was able to see in his lab what he had accomplished. And I left Dallas and went to Pittsburgh shortly after that and met David Adams, who is Adams Strategy. David, you may know.
I know David. Yeah, he's great.
He was teaching at St. Vincent's Operational Excellence. And so I had 2 years in Pennsylvania to sort of deepen my knowledge of Toyota production system as a management philosophy.
Yeah, and I think there were no relation. I think it's just coincidence that it was Jim Adams and David Adams.
Absolutely no relation. Yeah. Funny. I didn't realize you were the person that was at Children's. Too funny.
Yeah. Well,
that's awesome. Well, thank you, Mark. Thank you, Mark, for starting my journey you didn't know you started.
I'm glad to have that indirect impact. But yeah, I worked with them for a year or so, and that was such a great situation to be a part of, because between Jim Adams as the administrative director, who had a great background in military medicine before he retired and went into the civilian sector, just around leadership and servant leadership and systems thinking. And I don't know if you ever met his co-leader, the pathology director, Dr. Beverly Rogers, but the two of them together were just such good leaders who were focused on their people and systems and doing the right thing for their patients. That was really it was fertile soil for lean and Kaizen and continuous improvement.
Oh, it really was. I don't think I met her, but I walked away understanding that the lab was an island in a hospital. And he was frustrated at the time with batch work coming to him that he was trying to do one-piece flow with, and found that frustrating. And then I can't remember what the policies were, but he thought that senior leadership often created policies that didn't work well in that leadership environment. They did some great work, and we later sent a team of people from Signature down to see Children's Lab as a good example. Here's what I'm talking about when I'm talking about lean and what it can accomplish.
Yeah, and they've managed to sustain. The last time I visited the lab was maybe 2 years ago, and even though Jim and Dr. Rogers both ended up going to Children's Healthcare of Atlanta, and Jim has since retired. There was a good foundation there where their process for Kaizen and continuous improvement, was still very much active. It had just become the new expectation, and it had become the culture, especially with it had become the culture within the laboratory.
Yeah, that's great to hear, because I have always worried about what happens when I eventually leave Signature, or have we stabilized and hardwired this culture so that it will remain?
Well, maybe we can come back. I'm going to jot down. Maybe we can come back to that later on. But I want to take a deeper dive into your article. Again, the title was "The Healthcare Leader's Role in Safety." I really appreciated your reflections and what you shared there. But one thing you touched on in the article, I was going to ask you to elaborate on for the listeners. And again, for the listeners, I'll link to the article in the blog post for this episode. But I was wondering if you could talk a little bit about your initial reactions, going back 20 years now, to the Institute of Medicine report, "To Err is Human." As you were talking about, you've already, had been embracing quality improvement and had been working on leading that. But what were your reactions to those reports that had their estimates around the number of patients who died as the result of medical error?
I think my reaction, Mark, was very typical of the reaction I saw from other people at the same time. Total disbelief. That can't be right. There are not that many people harmed in healthcare. That certainly isn't happening in my hospital. Yeah, we may have a rare event, but that just I just could not believe it. And my style of curiosity and intellectual curiosity is, well, okay, then I'll go get the book and I'll start reading the research, and I will start sometimes looking at the references and going back to the original references to come to my own conclusion. Mm-hmm. I did not do that with IOM, but I immediately got the book and read the book, and then began to try to understand the research that they had done in the two states that I think led to that. I walked away from it saying, oh my goodness, this is a real call to the healthcare industry to do something about a problem that's not being discussed at all in any of the administrative meetings that I went to.
So, but one of the challenges, trying to go back to the original source or even with later studies is, my understanding of trying to come up with these estimates is, they do limited chart review, and they're trying to identify after the fact where errors occurred and if it caused or contributed to death. And then there's extrapolation, and it does in a way kind of invite people to question the estimates. But to me, I'm curious your thoughts. There seems to be this catch-22 where healthcare doesn't openly report the number of errors and the harm and deaths. So then people are forced into estimates. And then it seems like arguing the numbers maybe causes a bit of distraction from working on reducing harm. What are your thoughts?
Well, I think there's a fundamental issue in being able to see the harm that almost means you have to do chart review to get 2 and 2 to come up with 4 or 5. And that's because maybe the easiest example is there's something residing in the primary care office's note that would lead you down a different path. Patient comes into the emergency room. No one accesses that note or talks to the primary care physician. We go down a pathway that's incorrect, and it leads to harm. Well, you're never going to see that self-reported because nobody knows what was sitting in the primary care office's note that was available to us. But I think some of the studies do assume correctly that failure to have recognized something that was available to us is a mistake and a defect in the system. And if that failure led to harm, then that was something that was preventable harm. And we don't see it easily. There's so many handoffs in healthcare with the number of people in shifts. And, the nurse that unfortunately makes an error in medication, they wouldn't have made the error if they knew they were making a mistake. And so they don't see their mistake often. They thought they did what was correct. We may never actually know we made a mistake. Until someone draws blood trying to figure out what's going on with the patient, and then you may discover it. So it's really difficult, I think, to see harm, and then it's even more difficult to ascribe where in the process the harm actually happened and what the root was. Healthcare is just prone not to see it easily, and that does mean you have to do chart review, and that gets you the estimates, and people can push back the estimates. And yes, I absolutely think that the numbers get in the way of improvement, and frankly, it doesn't matter to me whether it's 100,000 or 400,000, whether it's the third leading cause of death or the second leading cause of death or the sixth leading cause of death.
Right.
I think all the studies tend to say there's more harm than there has to be in healthcare, and we need to do something about it. We should quit arguing about what the right number is and do something about the improvement.
Yeah. What are your thoughts, or what have you tried to do, even just internally, around encouraging reporting of errors, of near misses, of harm and risks?
It's one of the things I think we have matured our operational excellence system with culture of safety and are getting closer and closer to contemporaneous reporting of harm and situations, and sort of working through that stepwise over time. We've had the typicals fill out the computer report and send to quality harm, and that's, I think, a high barrier. It needs to be really significant before people are going to fill it out, and it often doesn't include near misses. It's more, unless a near miss was almost dramatic, like we almost did the wrong surgery. But the subtle near misses are not included in that system. We've moved forward over the years to finally having, during our huddles, which happen multiple shifts a day at the work site, what we would call Tier 1, we've developed situational awareness questions. And they're specific to the department, and they're done to help the staff think about situations they've encountered in the last shift that might tend to allow harm to happen. And it may be direct or indirect. It may be workload issues, to have more work than we can get in the people that we have. And then we have a catch program that we started calling Great Catches to begin with, and then realized that some people thought that had to be earth-shattering catch, and so we sort of took the name Great away from it and just call it a catch program. Both of those generate 8.5 by 11 list of issues that are on our multi-purpose board that get reviewed as part of our balanced scorecard system on a daily basis. And that is helping us see recognition of potential harm, near misses, contemporaneous in the workforce by staff doing the work. And those lists, contemporaneous lists, are feeding problem recognition problem sheets and our daily Kaizen or suggestion system. And that has become very rich over the last 2 to 3 years. We've finally gotten into a cadence in most of our clinical areas that you can go pick up those lists and see that there's something hitting the list every day.
Yeah. Yeah. And is there anything, beyond, local initiatives that different organizations have to try to, make it safe for people to report errors? Is there anything that you've heard of, or that could be done at more of a national level in terms of policy, or does this need to be just addressed within each organization?
That is a great question, because I think there's a couple of things there, and we're having an interesting discussion right now about how comfortable are we as a team talking about the near misses broadly. So we are still, even in our own organization, near misses are more comfortably talked about in the department, but we're not sharing across departments often. Had a great discussion with physician leaders and clinical directors yesterday of, are we to a point with our culture that it's okay to grab stories, de-identify the patient, and tell them, knowing that organizations may be able to figure out who was involved in the story? And there were 2 clinicians that said, well, that probably depends on whether you have been around for a long time or you're brand new to your practice. If you take a physician straight out of the residency program and they're involved in a near miss, they're not going to want it socialized in the organization because it's going to impact their career. But you take somebody who's been out for 20 years, they know that by the grace of God, somebody has helped them spot something in their practice, and they don't mind telling war stories. So very dependent on where you are. And we acknowledged as a team, you have to be careful doing that internally because you don't want to shut down people telling you about near misses. So you're balancing the value of telling the stories with people bringing them up. And that seems to be a nuanced issue internally. I've thought, well, if you had an issue, wouldn't it be great if there was a database you could go to so you didn't have to just de-identify the patient? You just take the scenario and go get a story from a website of, well, let me just print in enough to get a scenario and pull that story down and go tell that story and say, in another hospital, X happened. Because I think the stories are powerful. The Betsy Lehman Center in Massachusetts is starting a website where they are going to take state-reported data and they're going to try to create a way for us to get stories out of that database. They're just starting it. I haven't had a chance to go look at see if they have the reported issues in there yet or how we're going to be able to access them. But I think they are trying to get at the issue of how can we provide information that might help other people learn from the stories.
And Betsy Lehman, if I remember right, and listeners might have heard her name, she was a Boston Globe reporter who died after medical error,
cancer-related error. She was a Boston Globe reporter, and then in Massachusetts they established a government center in her name responsible for trying to improve patient safety in healthcare in Massachusetts, a non-regulatory, state-supported small group of people.
Yeah. So, we talk about, changing culture and developing, kind of new ways of thinking. And, one thing you touched on the article, you wrote, relearning how to lead after 30 years of success was difficult for me and all of our team. So I appreciate the kind of the humble reflection there. I was wondering if you could, maybe elaborate on that a little bit and also talk about how you help other leaders try to work through that challenge of unlearning and relearning different ways of leading.
There were a number of points of recognition in my own search to understand how the production system worked and work to understand what leader standard work was and self-reflection. And I kept running back into, boy, this is really hard because I have so patterned how I do administrative work and realized that, my pattern is set and confirmed because I had been successful. But if I really wanted to transform my organization, I had to be willing to transform myself. So I went through my own experience of writing down standard leader work checklist. And I just kept changing the checklist until I got into a cadence, changing my daily work, knowing that I had to do that. And I just keep laughing at myself of making a checklist and not following it and then having to do my own PDCA cycle. I remember someone coming in here once and saying, well, Kim, what's your PDCA cycle for your own standard leader work? And I thought, wow, I don't have one. What a fascinating question. which was really helpful for me. It's hard to change. It's hard to change what you've patterned with in terms of how you do your leadership work.
Yeah.
And I've realized that it certainly for the people below me, it requires a significant amount of coaching and patience, and a combination of both of those. And people, I do believe in Roger's work for change and how people change over time. And it takes a long time to have people change, and people change when they can see what works and they can learn from peers and they can emulate it and practice it and see that it's valuable. And that is a necessary process. And some people are late majority and they're not going to change until they see other people change, which means you have to just be really patient, take a lot of time coaching. And I developed over time leader standard work that has Gemba time built into it every day. I don't, as a CEO, always have time to get out in the Gemba, but we have scheduled time on our calendars in the morning, and people know where I'm headed if I can get there. And I usually bring the vice president with me, and I see that as coaching opportunity, knowing I have much more leverage with the VP and the managers than I do coaching employees. And I spend it as coaching time. And I spend much more time now coaching to help people be effective than I do actually working on problems anymore. Subtle change over time. But as that began to get traction in work, I really didn't have to worry about the problem. I just have to now worry that they see the problem, and then I have such trust that they'll go fix the problem if they just see it, whether that's a process problem or a leadership problem.
And so, Dr. John Toussaint, has talked about his evolution and his leadership style back when he was CEO. And, he said something to the effect of, not needing to have all the answers is very freeing. Would you agree?
It really is.
I hear you saying similar things.
Yes, well, it is. Not having to have the answers is freeing, and not having to solve the problem is freeing. And then once this management system is really working, senior leadership is freed up to go work on other things or handle a crisis in an organization while the rest of the organization fundamentally working on process improvement for quality and safety on a daily basis, because that system lives and breathes with its own energy. And we've found over time as executives, we've downloaded so much responsibility to middle managers and trusting them to do the work and improvement, that when we have a financial crisis year, the organization still meets its quality and safety improvement objectives because the people in the system closest to the work are actually doing that improvement. And we get to go focus on other things.
You going back a minute, you talked about being patient and realizing that coaching people, helping people change, takes time, and maybe not everyone is able to eventually come around. One thing you wrote in the article, you said approximately 20% of our leadership team chose to leave rather than change their leadership style. So I was wondering if you could just share a little bit more about that. What at some point did people see the writing on the wall, and they're being coached, and there's different expectations, and like, I can't sign on to this, or at some point does the patience run out and maybe people are asked to go someplace else where they can still operate that traditional way?
It's a great question. I was seeing multiple points of recognition, I thought, from various directions in the organization, that we did not have the senior team aligned, and because the senior team were on a bell curve of change themselves. We had people that were late majority and people that were early majority, and they're coaching people that were early majority and late majority. I would pick it up when we would, in quality meetings, review problem sheets, and I would see problems that were being worked by a manager where the senior person had signed off on their work, but it really wasn't a very good point of recognition. They hadn't gotten to the root cause, and they were doing parallel processing, and they really didn't understand the system. And their demand and their area had very few suggestions. And if you went to look at their area, they were stymied. But if you asked the senior manager how they were doing, they would say they're doing an awesome job, because you had a late majority making that assessment. And so I started making really structured rounds, trying to hit areas under all vice presidents, and I saw more points of recognition of what I thought I was seeing. I saw early adoption all over the organization, and then alignment issues of the senior team. That led me to working with the lean staff on competencies. I thought, okay, well, we need to get in writing this system, and in writing what competence is, both in problem solving and what's competence mean in terms of standard leader work. So we developed a competency grid. And then we started using the competency grid to make rounds. And that grew to me including multiple senior people plus lean plus human resources in making rounds. And we were using the competency grid to really talk about what are we seeing as a senior team. That helped me align the senior team. So we got on the same page about what we were trying to accomplish from a leadership, organizational effectiveness, philosophy, and standard. But then I was still seeing tremendous variation in managers. And I finally reached my own inflection point of, we were about 3 years into operational excellence. We have what I think is probably 40% or so of the organization still really not trying. They just weren't leaning into using the system. They were trying to do their routine work and do some lean problem solving, just enough to get by. And we decided to take this competency grid, and I went out on a limb with the organization and said, okay, enough's enough. We're establishing this is the standard. I've said it was the standard. It is the standard. And if it is the standard, then we need to measure to the standard. And if a manager chooses not to manage the way we're going to manage, and we've declared, then they shouldn't be a manager here. And we decided, or I decided on behalf of the organization, that we would hold raises for a year for anyone that had been here long enough to understand the system but was not competent in using the system. But that we would pay the raise whenever they accomplished competency during the year. I wasn't really interested in the financial savings. I was interested in change. So I said, if you get a raise halfway through the year for being competent, I'll back pay you for the rest of the year from when the year started. I didn't want anybody to be able to say we're doing this for a financial reason. And when we implemented that, people self-selected out. I think that was the signal to the organization, this is real. Some people self-selected and were very direct with me when I talked to them as they were leaving. I really don't want to manage that way. So I went and found a job somewhere else. I think that was helpful to the organization. And if I'm fair and honest with myself, I created tremendous fear in the organization. It's taken us years to get past that inflection point. As I've then made rounds in subsequent years where we weren't using the competency grid anymore, because we did that for 1 year, sent the message to the organization, got people competent, and then abandoned the test. But people still felt like they were being graded for a test rather than coached. It was taking a few years to get past that inflection point. And so I've had to really work hard at getting past that over time. I do think it helps speed up our implementation. The other harm that created is I think this happens probably in implementation when you do it across the whole organization, because we implemented organizational effectiveness in about 110 departments simultaneously, all up system-wide. Everybody's up with what I would call the sort of Toyota production management transparency daily Kaizen system, where we were experiencing management turnover in those first 3 to 4 implementation years. The staff in those areas never got into a cadence of really understanding the system. So the third manager going into a unit had no current system working for them to engage with. We as senior leaders are 5 years in, totally understanding the system and what should be. And we would forget that, this manager's only been here a year, and it's a manager that's in a unit that has turned over managers every year for 3 years. And we needed to back off our expectations and become much more patient. We went back and grabbed that competency grid and created a 2-year orientation process for new managers so that all senior leaders would acknowledge, okay, let's don't hold people responsible for knowing X until they've been here 6 months, 9 months, 12 months, 18 months. And that slowed us down, helped us, I think, reduce our turnover. We're now far enough into this, a new manager can come from the outside and learn it almost by OJT, because the systems are running at the daily level in departments. But working through management turnover during an implementation was really hard.
So going back a little bit, could you elaborate on, or could you talk about why it was important to not frame lean or these efforts as being focused on cost and finances?
Oh, yeah, I totally believe that you have to reach the hearts and minds of people to get them to change. And I think you reach the hearts and minds of people in healthcare. Most people, regardless of the job in a hospital, went to a hospital or a clinic to make a difference for their community. And that's what drives them every day. And I believe that daily improvement is something somebody willingly gives on their own. And I believe in this whole management philosophy of the power, from a power perspective, the power I have as a leader is to terminate somebody. And any work they would do less than a termination level, I'll term for. Anything more than that was self-will. And there's a tremendous amount of self-will that we're responsible for getting from people. And self-will has to come at their choice, and because they want to give it to me, which means I don't have the power to make them. Therefore, I have to get to their hearts and minds, and we lean heavily into that. And I think the whole finance notion takes you away from doing things because it's the right thing to do. I do believe that finance will come. You dechaos the organization, you take defects out, you improve process, clinical quality, then finance will follow. But if you lead with finance, people won't even try.
And I like the way you put that, dechaosing the organization. That has a different implication than talking about eliminating waste, right?
Oh, I finally learned over time. 6S wasn't just the supply closet. This 6Sing is a layered thing that I now understand of what I call dechaosing the organization. We focus on what's important, and we get rid of enough defects and chaotic behavior that you can actually see defects when they happen and see important defects and work on them. And it's an alignment strategy, but it's only happened over years that we've reduced enough defects, waste, and chaos that it's allowed us to focus on things that are easier to accomplish but are really critical for us to put our efforts in.
Yeah. And touching on things that are really important, in the article you talk about working towards zero harm, and you describe that as a moral obligation, which is I think that's also very strong evocative language. Why do you frame it? I don't disagree with you, but I'm curious. How did you come to frame it and describe it that way as a moral obligation?
A couple of things, Mark. One, it is strong language on purpose, because I think language really matters when trying to reach people's hearts. Then the language we choose to use needs to grab them and shake them out of their current belief system. So that's done on purpose. I went through an exercise with our managers of taking gold coins and dropping them into a silver bucket, each coin to represent a certain number of deaths in America. And I used it through a management meeting, and for the entire meeting dropped another coin and said, I want another moment of silence for another person who's died in American healthcare. Because I wanted to get through to people. We're talking about patients, we're talking about families, we're talking about people's lives. And I think we need to grab that emotionally, and through that emotion have passion. And I've become to understand, I think, much more about Reason's Swiss cheese than I ever knew 30 years ago.
Right, the Swiss cheese
Reason's
model.
Really talking about, and what I thought he meant was the slices of cheese were things like the barcode system and the Omnicell, or the dispensing system, and the electronic medical record doing away with reading handwriting issues, and pharmacy double checks. Those were all the defenses he was talking about in the pharmacy delivery system. But that's really only part of the story. I only understood later that Reason also includes organizational impact, and does the unit pride productivity more than they do safety as another slice of cheese, or another defensive system, and that supervision is another defensive system, which means senior leadership has a defensive system, and the board has a defensive system, and media and the public and have a defensive system. And if there are holes in any of those systems, those are just as important as a hole in the barcoding system. I never had a fundamental understanding of that. But once I understand it, Well, that means I own a slice of cheese as an executive.
Mm-hmm.
And that means to me I have a moral obligation to close as many of those holes as I can in that slice of cheese, because it might be my hole that opens up a patient for harm. And that's just as responsible to me for harm that happens as it is the individuals delivering the care.
Yeah.
And that becomes then a moral obligation. Once you understand it, you've got a moral obligation, I think, to close the holes, and they belong to us.
Yeah.
I don't think that's fundamentally understood by a lot of executives.
Yeah, and so in the article, and I think this is what you were getting at. You said my belief that a hospital could be error-proof and checklist its way to zero harm was fundamentally flawed. Is that because it was missing that leadership responsibility for systems, or
a couple of other things I've learned.
Missing?
Oh, well, yeah, I think there's a couple of other things I've really become to understand more. And maybe it's just the way we implemented Lean, but we implemented Lean as process improvement. And in some cases had administrative processes in that. But I never fundamentally understood that if it is not a knowledge issue, and let's go back to a medication process, which has a lot of process in it, all the error proofing and processes in the world doesn't necessarily help the individual delivering the care make a personal decision about what happens when the barcode wand reader is not working. What do? Yeah. Do they honor productivity over safety? Does the person set it down and go find another one that works and come back in the room because they would never do it without it? Or do they bypass the system, because all of our systems have bypasses?
Yeah.
And that becomes a compliance with known rule issue. And then as I understand compliance with known rule issues, I now understand there's like three components to compliance to known rules. One is what are the barriers to complying? Well, that's where process improvement has its clear ability to help. We have to remove the barriers. I got to make sure the barcode wand has good battery in it. But then there's a perceived risk issue. That's all leadership, and that's all culture of safety, and that's an obligation of leadership to work on perceived risk, which gets you into catches, sharing stories, and elevating the perception from an individual at the point of delivery that they're about to do something that might have risk with it. And the third issue in following known rules is what coworkers are doing. So we have to make visual somehow that coworkers are all doing it this way, and coworkers honor safety more than they do productivity. That is, again, another leadership issue. And one form of getting to zero harm and high reliability has to be managing following known rules. And I think that, like the airline industry understood this years ago, their whole cockpit training is around that effort. And then I think there's other subtle issues in healthcare we have to acknowledge. There are over 200 forms of cognitive biases. So when we are thinking about even something as simple as, well, is the behavior I'm about to perform a risk? We have a cognitive bias about not being able to see what we do today having significant risk related to it. There are people that think 1 in 1,000 seems like low risk.
Yeah.
1 in 1,000 in medication delivery means we're going to make a lot of errors on a fairly frequent basis. When you look at it, what's the chance of an error in a day? Pretty high.
Right.
Chance to an individual, pretty low in their mind. And so managing cognitive biases, I think, are important. Well, how in the world do you manage a process that you can't see because it's how people think? And I realized but that's extremely important. And I'm never going to get to it through a visible process improvement methodology. So we had to come alongside process improvement with an entire process aimed at how do people think, how do people perceive risk, how will people work in a team, will they speak up, do they see potential risk, and those were all unseeable in terms of observing work going to the Gemba, things that we needed to do. And in our work in Lean, we're really different from process improvement.
And, we're going to wrap up here. And, I want to talk a little bit about some of the results and the success. I appreciate that you've shared your reflections on challenges and things you would have done differently, and I really appreciate that. But in the article you talk about reducing serious safety events by 80%, and you shared the reflection of you wrote, if anyone had told me 10 years ago that we could reduce our serious safety events by 80%, I would not have believed it. So I was wondering if you could share a little bit more about that success, and is it chicken and egg? Do you see results and then believe it, or did you in different ways, maybe being inspired by others, realizing yes, it was possible, let's commit to it?
I think it was seeing results and then believing. It's interesting, and because we are in an industry that is not highly reliable, comparing yourself against the industry, we were often better than the average. So over years, when you're better than the average, and in many Medicare measures, we were in the top 10% in the country. We had dramatic improvements in worker injuries. Our employee injuries had gone down by almost 90%. For things like pressure ulcers, falls with injury, CLABSIs, CAUTIs, most of those were down by 90%. We thought we were really good. We'd been a safety A in Leapfrog for year after year. The only time we've had a B was the very first 6-month interval. We've been straight A's since then. We thought we were doing an awesome job. We brought in someone to start helping us measure healthcare performance improvement, the people that are owned by Press Ganey now. And they created a measure of serious safety events. And they told us that if we implemented cultural safety, we'd see an 80% decrease in serious safety events. I thought it's not possible in our organization. We've been safety A's for this period of time. Our measured through chart abstraction in the Medicare and other forms of things people were focused on were 80 and 90% already lower than expected. They came in and said, wow, your serious safety event rate, the way we would measure it, is really low. So we don't know if you're going to see an 80% improvement. We doubled down, implemented culture of safety holistically, just like we did organizational effectiveness, and we saw our serious safety events drop by over 80%. I was honestly shocked. I didn't think I thought we would see an improvement. I didn't think we'd see that level of improvement, and we seem to have sustained it over time. So I guess I have to say and admit, we brought in somebody else to measure something we weren't measuring before, and implemented things that we weren't doing before that helped people feel much more safe telling us about near misses than we had ever seen before, and then saw a tremendous drop in safety events.
Wow. And maybe one other question here. You brought up earlier the importance of succession planning. Is there anything more that I'm not trying to push you out the door, but is there anything else you want to share about some of your plans for that, at least?
Yeah, and I'll go back to a rare event for me, and I think rare for CEOs. How often does a president of a hospital get to go back to be the president of a hospital they had been the president of before, with an interim gap in between? When I was at Methodist Hospitals of Dallas, I was leading one of their institutions, left to lead another one, and then we decided to build a third hospital, and for a period of time, I was the operating officer over both hospitals, which included the place I had been at previously. I had an opportunity to witness a lot of the management systems I had put in place had disappeared over the intervening 2 or 3 years. It was a tremendous lesson for me. And I'd been there for either 10 or 11 years as the president of that hospital. And I thought when I left that some of those management processes were hardwired and they were going to stick. Within a couple of years, they were gone. I've never forgotten that. Knowing how difficult I think implementing operational excellence is across the system, from day one, I've worried about how do I do this at a pace that will more likely have it stick, and then what else do I do to help the organization value it so that it will stick. One of the things we did with the board support, which is a great board here, is we added 2 lean experts to our board's quality committee. Changed our bylaws, opened up 2 seats on the trustee quality committee, 2 seats dedicated to professionals in operational excellence who had plant manufacturing backgrounds that sit on that committee. One of them is also a board member now. The other one continues to serve on that committee. And then throughout the years, we've done lean training for our board in hopes that they would understand when they see improvement here over time, it is because we have a lean operating management system. And I have those 2 people in the documentation of CEO succession planning. I don't know if the board will follow it, but my suggestion has always been, go grab those 2 lean people. They're there for you to help you find the new CEO. Because when people talk about lean, they might be a project person, but say they've really done lean holistically in the organization. And then there's operational excellence people that really have a management philosophy, and they're different. And if you're not an insider in the industry, you can't pick up the verbal cues that might tell you what kind of experience someone has, and they really need the expertise. They've been now around for 5-6 years. So that's one. Trying to convince the board by storytelling our improvements, 2. And then 3, the work I've been doing the last couple of years, telling our story locally and nationally, trying to build pride in the organization, have people feel really good about what they've accomplished, have them not want to see anything slide. We even now have started presenting some of our clinical data with 5- and 6-year run charts, because we're so good and stable now. You no longer see, wow, it used to be much higher than it was. And I'm afraid with management turnover, people come in and just assume, oh, wow, your rates of infection are really low. Oh, but if you just knew where it was before, you might be more willing to say, when it sneaks up a little bit, you see the drift up. And so we're presenting data in a way that I'm hoping helps my whoever comes after me spot variation and trends over time. I'm doing everything I can to poke at our systems that might create visual ability of the next person to see trends over time drift back if it does after I leave. And I think that's all I can do. We have a good succession planning process with the board and the board's comp committee, and talk about multiple levels. We try to promote from within rather than going into the outside. We find it's easier to do that. It's easier to self-develop now than it is to bring someone in from the outside. But CEO succession is, I think, really critical to stabilize this level of management philosophy.
Yeah. Well, Kim, I really want to thank you for what you've done and your willingness to share. Really appreciate you taking the time to do this. So, again, I want to encourage the listeners to go find the article, The Healthcare Leader's Role in Safety by our guest, Kim Hollon. Kim, I'll give you, I guess, the last word if there's anything else that you'd like to share with the audience before we wrap up.
Oh, thanks, Mark. I just kudos to the team here. This is mostly the team that I found when I came here, other than some turnover 4 or 5 years ago, is the team that exists. I think all I did as the leader was establish a system and get out of their way and coach them. The capacity for this team to sustain change over time has been a humbling experience. They are an incredible group of people, and they deserve really a lot of credit for transforming the system.
Well, thank you again, Kim, for being a guest here on the podcast. Hopefully we can do it again sometime. There's plenty more that we could talk about, I'm sure.
Boy, there's plenty more. There's plenty more in the story about what I think I've learned and operational excellence and lean and culture and safety. And Mark, I really have been shocked as we've implemented sort of what I would consider the human performance tools and added it to lean. There's a synergy there that I couldn't have predicted.
Mm-hmm. Well, it seems like you're going to keep learning. So
never a day. Never a day I don't.
So let's
Thank
catch
you.
up again
Hey,
sometime about the latest you've learned.
Yeah, and thanks for sending the thanks for doing the podcast, and thanks for retweeting the article.
Oh, very happy to do so. We'll talk again soon, I hope.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.